All right. Well, good morning, everyone. My name is Ryan Coaches. I'm the manager of Biometrics. My background is as a respiratory therapist. I'll be presenting in December, so I'll kind of go over more of respiratory then. Um, and I'll have this is Kara Jackson. She is our lead echo tech. And we're going to highlight some of the areas of biometrics, and we'll highlight echo a little bit. We have some stuff to show you on echo, and then we'll kind of go over the other testing we do, um, in this department. I'll let Kara kind of tell you a little bit about herself and how she got to be in the echo world.
Hello, so my name is Kara. I am a registered cardiac sonographer. I've been doing this about 10 years. I've been at Mercy just over 2 years now. And when I had first graduated from high school, I didn't know what I wanted to do. So I actually got married and had 2 children. And after they were born, my circumstances changed and I needed a career that would allow me to provide for my children. So that's when I found sonography and went back to school. I actually went to school down near Columbus at a school called Central Ohio Technical College. Took me about a year to do my prereqs, which are like your anatomy and physiology, your sciences, math, English, psychology, things like that. And then once I was in the program, it's a 2-year program, and I graduated with an associate's degree with a specialty in cardiovascular sonography. The last year of the program, you're typically in a hospital setting or a clinical setting 4 days a week, up to 32 hours a week. So it's a very intense program with a lot of hands-on training.
Okay. So as far as our normal days and things like that, we interact with pretty much, and I think the hospitals like this generally, you interact with almost every department in the hospital. Most people that are here are getting multiple tests. They're seeing multiple doctors. In the biometrics, you can see we have echocardiogram, which we deal with the cardiologists, EKG also with the cardiologist and the admitting doctor. EEG and EMG, which we'll kind of explain what those are. We deal with the neurologist, which is the brain. And then PFT is the pulmonary function test. That's a lung test we do. We deal with the lung doctor or the pulmonologist. And a stress test is also the cardiologist. We'll read those. Obviously, when you come into a hospital, you have an admitting doctor. We call them hospitalists. You have your specialty doctors, depending on what your issue is. So we interact with all different kinds of physicians throughout the day. We interact with the nursing on the floor, the nursing in ER, with lab, with radiology, which I think you guys had last week. You guys learned a little bit about radiology last week. So you see all those different areas there. Like I said, these people are getting tested in many different ways. So we do all these testing in patients. We do. Those patients are in their rooms. We actually go to the rooms and do testing. And then when they're outpatients, they come in and we have testing rooms to do it in. So and I'll let Kara kind of tell you the kind of patients we see with echo and stuff.
So we can see anything from a normal, healthy-looking patient walk in just fine, back to our echo room, lay down like we need them to do the echo, just appears completely normal. And then we can also see very, very sick patients up in the ICU. In the inpatient setting, some can't even, keep their eyes open while we do the test or tell us their name and birthday. So we really see a wide range of patients in the testing setting. We also do echoes 6 days a week. So you do need to know that when you go into echoes, you will be required to maybe work holidays, weekends, and we also have to take call here at the hospital in case of emergencies the patient needs us to come in for. So.
And just to kind of touch on what she said about scheduling, I mean, it's just getting into healthcare is very rewarding. I mean, we do a lot of good things and we have a lot of great outcomes. But, like she said, you do have to work some nights and some weekends and holidays and stuff like that. But it kind of comes with the territory when you get the satisfaction of helping people and seeing people get better and things like that. So, but that's just something to be aware of and something to know when you're getting into healthcare. But not to scare you away from healthcare, but it's just something that you guys should know. So, We're going to kind of, any questions so far from anybody? You guys awake? Everyone awake? Everyone having a good time? Are we entertaining you guys? Yes. Okay, I got a couple thumbs up. All right. All right. So far, so good. No one's sleeping yet. The first group, we had 3 people fall asleep in the first 2 minutes. So our presentation has gotten better. I'm going to have Kara we're going to start with echo. We're going to kind of show you guys some echo slides and things like that. Kind of show you like the basics. It's pretty interesting. Let me, how did you do this? Just trying to get this to play. Okay. And I'm going to have Kara kind of go through and kind of explain just the echocardiogram and things like that. So
this is an image of the heart. An echocardiogram is an ultrasound of the heart. So we are actually looking at the inside of the heart. The test shows the doctor how well your heart is functioning. So how well it's squeezing and relaxing. You have 4 valves in your heart that we take a look at, the aortic, mitral, tricuspid, and pulmonic. We can also show the doctor the direction the blood is flowing through those valves with something called color Doppler. And we also look at the velocity that the blood is flowing through with something called continuous wave and pulse wave. So the cardiac sonographer is the one that performs the echo. We take all of the images, but then a cardiologist reads it and dictates the study. And we can actually take 3 to 4 beats worth of little video clips so the doctor can actually see the heart moving. And like I said before, usually about a 3-year with your prereq courses to complete your schooling for this. So this will just show a little video of what an echo would look like. So here you can see this is the left ventricle with the mitral valve opening and closing, and then up here is the aortic valve opening and closing. This color shows the direction of the blood flow. This is the left ventricle. That's the main squeezing chamber of your heart. And then this shows all 4 chambers. So in an echo, your atriums are on the bottom and your ventricles are on the top. This is the left side. This is the mitral valve here in the center, opening and closing.
And basically what's this showing is it's amazing if one little thing is not working correctly, one little valve, the blood's not flowing in the right direction. It's just amazing how how these tests can show the doctor exactly what they need to see, how they can diagnose all these different issues. Very interesting.
So not all the echoes that we do are normal. We can find a lot of abnormalities on an echo. This shows what's called a pericardial effusion, or it's fluid around the outside of your heart. So if you look at these images, all of this black here is fluid that should not be here. And if it gets so large that it doesn't allow your heart to adequately beat, then the physician will have to go in and drain that fluid off of your heart so it can pump the way it needs to. We can also pick up something called a vegetation or endocarditis. What that is it's actually bacteria that was in the patient's bloodstream, and for whatever reason it attached itself to the heart, usually on a valve. This one right here, you can see this white image right here. This is attached to the patient's mitral valve. So what will happen for that patient is they will be put on a high dose antibiotic to try and get rid of that bacteria so it doesn't cause permanent damage to the valve. We can also see a thrombus in this patient. It's in their left ventricle, or a blood clot. We see a lot of patients that have had a heart attack and the heart muscle is weakened, so it's not adequately pumping the blood out of the heart. Blood kind of pools there and it is stagnant, so it creates a clot. So this patient would have to be put on high dose blood thinner to try and dissolve that clot.
Yeah, I just want to go back to something here that she was talking about here. Sorry, this is It's freezing up every once in a while. Just to go talk about the pericardial effusion. If you imagine like your fist is your heart, and you can open and close your fist like this. Now take your other hand and squeeze it as hard as you can. Now try to open your hand. It's not going to open up. It's not going to squeeze. So normally your heart can just open and close. You have this pericardial effusion. You have all this fluid around it. Squeeze your fist. You cannot open your hand. That's kind of like the heart. If there's anything surrounding the heart that's not allowing it to use its elasticity to open and close, your blood flow is going to be affected, and a lot of your whole function is going to be affected. So just to kind of put that into comparison, same thing happens with your lungs. If you get water fluid around your lungs can't open and close correctly. So these are just some of the issues that you can see. So just wanted to kind of go over that, but I'll let her get back to see where we're right here.
So then not all the patients that we see have beautiful images. So they have created something called Definity that helps us see your heart muscle working a little bit better. What it is it's just tiny microscopic fat bubbles suspended in a gas. It does require the patient to have an IV, but then a nurse would put this through the IV, and those little bubbles give my sound beam something to bounce off of. It kind of acts like a light bulb in your heart. So you can see this first image up at the top. I don't know where my cursor is. You can't really see the whole heart muscle adequately.
I don't know if you guys are having a hard time seeing our cursor, or it kind of keeps disappearing for us. So.
But then you can see this over here kind of acts like a light bulb, so it brightens up everything so the doctor can actually see the heart muscle pumping how it should. We can also do something called a transesophageal echocardiogram, or a TEE. That is done with a cardiologist, and they place our transducer in the patient's esophagus. So you're a little bit closer to the heart. You can see everything you need to a little bit clearer. And we see abnormal things on those also. This picture over here shows a clot in the patient's right atrium that should not be there. So again, this patient would be put on high dose blood thinners to try and dissolve that clot. So this is going to be a short video of what's called a bubble study. A lot of patients that have strokes or stroke-like symptoms, TIAs, would get a bubble study with their echo or TEE. And what that is it's just agitated saline that the nurse puts through the IV, and it comes in the right atrium, and it should stay on the right side of your heart. Nothing should cross over to the left side. If it does, that is indicative of a tiny hole in the patient's heart, or a PFO. So you're going to see on this video, the bubbles are going to come into the right side, and then right around here, you're going to see a little shoot of the bubbles come through. That is coming through to the left side. So this patient does have a small hole in their heart. Depending on the patient's age and symptoms, they have come up with a closure device that they can surgically insert in that little hole to help the patient resolve those symptoms, so they don't continue to have strokes or stroke-like symptoms or TIAs.
Quick question on that. I mean, you said depending on the age, would it be younger? I mean, do people live their life until older age, meaning like over the age of 40 with a hole in the heart, and they have no idea? Or how does that pretty much, I think it'd be a big concern.
So I have seen patients as old as 70, 80
really?
years old that we do a bubble study on, and it's positive, and they have never had any symptoms until that hospital stay.
Because that would be genetic, correct? I mean, doesn't happen through wear and tear. That's a genetic defect, correct?
Exactly. They were born that way.
Wow. Okay.
Yep. So typically, if a patient is younger, I've even seen people have closure devices in their 50s because they just continue to have recurrent TIAs. They're healthy otherwise, so the patient will go, or the doctor will go in and put that closure device in to try and alleviate those symptoms for them.
And then I'll briefly go over some of these other departments in biometrics. EKG or electrocardiogram. Basically just shows the electroconduction or the rhythm of the heart, just the basic rhythm of the heart. We put 12 leads, right? You can kind of see in this picture here. And then this is kind of what the normal, not to get into too much detail, this is what the normal heart rhythm should look like. This is a normal EKG. The normal heartbeat is 60 to 100 per minute. That is a normal. If you have some people have 50, some people have 45, some people have 55. That still can be normal. This is just the basic. Is 60 to 100 is, they say, is a normal heart rate. Some people live at 110, 120. Doesn't mean anything's wrong. It's just that that's what they use as a baseline for that. And it's amazing. All of these little spikes and stuff that look like a mess right here, like someone was scribbling. It means something. Every little line, every little part that goes up, every little part that goes down, the physician's looking at that to say, okay, is the heart beating properly? And then when the heart's not beating properly, you get into an irregular rhythm or an arrhythmia. So that's how they can tell an arrhythmia. So you can see here, just like I said, I'm not going to get into too much detail, but basically just by reading this, they can tell if your heart's not beating correctly. This is just another example of, obviously this looks a lot different than the one we saw before. It doesn't have any rhyme or reason to it. But you see something like this, call a respiratory therapist, okay? And a cardiologist. This is another one. They'll probably need, most of these patients will need defibrillation, medication, and some intervention from the physician. This just shows you the different segments and stuff. The P, Q, R, S. This is freezing up. P. This is the Q, the R. And then at the top is the S. And then down here is the T. So all this here is important. This is what they're looking at. This is the stuff they're looking at to make sure everything's okay. But these are the EKGs are very common tests. They do those almost to anyone who comes in the hospital, just to rule out. The first thing they're going to rule out is any arrhythmias and things like that. That's a very common test that they do. Most clinicians can administer an EKG, the actual EKG itself. Obviously, those are read by the physician, and then if it's serious, the cardiologist will get involved. EEG is a test that we do for, it detects electrical activity in your brain. This is read by a neurologist. It is performed by our EEG tech. EEG techs are kind of trained on the job, but most of them have vast experience in the hospital with patient care. But we do train people to do this kind of testing. And we cross-train a lot of people to do multiple tests. So some of our EEGs do EEG, EKG, and EMG, which I'll explain next. Some can step into the stress lab. Some can do stress lab, EKG, and EEG. So you can do many different things with this kind of stuff. This just shows you how the setup is right here. These are the leads they put on the brain, and these are the brain waves right here. By looking at this, the neurologist can kind of say, okay, this is normal, this is a seizure, things like that.
Just 1 second. So students, we're starting the nervous system, neurology in our pathology unit. So you're going to see in the diagnostic sections of almost all of the nervous system disorders where they recommend an EEG. So just to kind of give you an idea what the patient would have to set up with and look like. Do those electrodes stick to hair, or how does that work? They don't need to shave, do they?
They do not. No, they're either with like dissolvable glue or pieces of little tape. Yeah.
We give you the option though. If you want to shave your head, you can. But I mean, yeah, then you can diagnose epilepsy, other brain disorders, all different kinds of stuff. So it really just, it's all about the electrical impulses, which is pretty crazy in itself to think that you could put a lead on someone's head all over and kind of get brainwaves. It's pretty cool to actually think about how it seems like a simple test, but it actually can tell the doctor a lot of stuff about the brain. So just want to go back to this one. Let's see. I already did the EEG. EMG is another neurological, it's not a brain disorder, but it's another neurological test we do, basically for nerve cells and muscles. A lot of carpal tunnel, ALS, if you guys ever heard of that, the Lou Gehrig's disease, muscular dystrophy. So just basically muscle use and nerves is the basic gist of this. Again, in EMG, no schooling, but we cross-train them. We train the staff. Again, most of them have vast experience doing other kind of testing, or have worked with a neurologist, or have been in some type of hospital setting. But it's stuff you can learn, you know, especially if neurological conditions interest you and stuff like that. So, just waiting for my cursor to show up again. It keeps disappearing. There you go. This just shows how they set up these are the nerves here, and this is how they test them. And they got the leads on and things like that. And this one's here for the muscles. They actually use a needle to do that test. PFT is a pulmonary function test. This is a respiratory or lung test. Diagnose things like asthma, COPD, any other type of respiratory conditions you could be having. PFTs, technically, most PFT techs are respiratory therapists. There is a PFT license. We do not require it at this time, but there is a license. I'll get into respiratory a little more when I do the presentation for respiratory, but respiratory is a 2-year associate's, and we talk about moving it to a 4-year bachelor's. Obviously, you have to do clinicals. A lot of people come in shadow first, respiratory, and kind of see, just like every other area, and kind of see what you like. That's probably the best thing, is to actually see what people do every day on a daily basis. But this is done by the tech, and then the pulmonologist, which is a lung doctor, will read the test and kind of go from there, whether it needs medication adjustments, anything like that. This just shows you that there's a spirometry machine. You have to do a series of different kinds of blowing, inhaling, holding your breath, blowing out quickly, taking deep breaths in and out. It's a pretty tough test to do, you know. And then it's read all back on through the machine, through the computer, and then they can see your volume and loops and things like that. And then the last thing we'll talk about is stress test. Stress test is another cardiology test that we do for the heart. Pretty much most of the patients are on treadmills. They're hooked up to an EKG that we discussed earlier. And as you're working, as you're stressing your body out, it kind of just makes sure it checks for changes in your EKG and basically tests the heart. We have a registered nurse inside of the stress lab at all times, also an EKG tech or a stress tech. Those can be trained. The stress test can be someone who has history with cardiology. Our current stress tech is a paramedic, so she has she's taken EKG courses and knows a lot about that kind of stuff. RNs, which you guys will probably do some presentations from RNs. You'll get to learn a little bit more about that field. But we do have an RN in there at all times, because she has to, like Kara said, do IVs, push medications, things like that at times. If something goes wrong with the stress test, they see something, sometimes you got to give medication to kind of bring the heart back down. Let's see what else we got here. This is just a picture of some guy on a treadmill. Looks like he's not having a good time. And see, this I wouldn't, if this was my stress tech, I would not accept this. Look, there's no smile on the face. You see this? Not smiling at all, not having a good time. I would be having a discussion with that.
Ryan, you're such a great comedian.
Yeah. Well, I'm kidding, but I'm not. You know, you got to be, when you work. You know, you are here for the patients, so you know you got to be happy. You're not always going to have the best time, but you got to be happy. You got to treat the patients well, and you got to enjoy your job. They're here because they're sick, and our job is to take care of them. So again, we do a lot of different testing, and we all work together. We work with pretty much every department in the hospital. You guys have already talked to radiology. You'll be talking, I don't know if you guys are doing lab or anything, but everybody, you name it, we work with them. So it's a really group effort to take care of the patient. So do you guys have any questions about what we showed on these slides?
I just want to touch base, and I asked this question to radiology last week, and I'm curious to see how your response is. So there you are with a sick patient, and it's intimate. You're right there. You're doing the assessment on them, and they ask you, so what's wrong with me? What do you see? I can't wait to talk to the doctor about this. I'm losing sleep, please, beg you, what do you see on the screen? What is wrong with me? How do you handle that?
I'll let you speak from an echo perspective.
For echo, we really do have to have a really good poker face because we are not able to diagnose them. So my line usually is, I am so sorry, I can't give you results. It'll be just a couple days. The physician will read all of these images, and then they will let you know how everything looks. It's not the best answer, but we really cannot give them any answers. So.
Yeah, and when I do for respiratory, again, we'll get into this when I do it. We have to do some blood cultures. We do arterial blood gases. I'll have the results in front of me, and they'll ask me, "Oh, how is it? How is it?" And I just say, you know what? I don't read them. I just do the testing. I said I don't want to tell you something that might not be correct. The physician will tell you something, and I think that usually, like if I say that, like I don't want to tell you the wrong information because every doctor has a different stipulation on what's normal for that patient. What's normal for you might not be normal for me. Doctors might accept different values for different patients. So I always say it's up to the doctor to decide what is right for you in your situation.
Good one. I like that one. But put it on the doctor.
Years of practice. No, it's tough because when you're new, you're right. It's scary. You walk in the room, and the patient's like, what's going on with me? You get nervous. What do you see? What's going on? Like, you really, it's a skill to learn. But basically, we just tell people, even when they're new, like if a patient asks, just say, "I'm sorry, I cannot discuss the results because I am not a physician or an NP or a physician assistant." They read the testing. We only perform the testing. So, you guys have any other questions about the presentation? Testing part of it?
We all good, guys? You're gonna do well on the post test. Perfect post. Okay, everybody's got thumbs up, so they're feeling cocky. They're gonna do well.
Everybody knows the 5 chambers of the heart, right? Right?
Actually, that is one of the questions. Very good.
Yeah, you should know all 5. You
5, right?
5 chambers. Yeah.
5.
Yeah. So just something else to kind of get into, just about as far as healthcare, I have a few different departments under me, so I work with respiratory and echo and all these different departments and stuff. And I think it's important when you get into healthcare, there's certain things that is like certain skills you need to have. And I would say you got to show initiative. We have students now. I can tell within the first day of students here as in their clinicals if it's somebody that I would hire. I'll give you an example. I was coming in, we were really busy. I was helping out the respiratory staff the other day. I brought in a vent to clean. I just started cleaning it. A student from the other room popped up and said, "Hey, let me clean that for you." That right there, I said, you know what? I would hire that person. Not because I didn't have to clean the vent. I mean, that was a nice perk. I didn't have to do it. But basically because you know what? You help each other. You shouldn't have to be asked to do things. So I think initiative is a huge skill to have. Don't just sit there and wait to be asked to do something. Ask. Say, I want to learn. What are you doing? Can you show me? Can I come with you? Another thing is you've got to be a good team player. Everybody works so close together in the hospital. Every department, it's all a well-oiled machine when everybody works together. Positive attitude and a willingness to learn. I don't care how long. I have some respiratory therapists that have been doing this 30 years, and the good ones still ask questions, still want to learn because technology changes and the fields change. And I'm sure Kara can speak for that from the cardiology standpoint. It's ever changing, so never settle on what you know. Always want to learn more and be willing to learn more. Be coachable, be teachable. Those are skills to have when you get into healthcare for sure.
I don't know if you can answer this, but with COVID on the rise, and I think I don't want to steal your respiratory therapy thunder in that presentation, but what are some things that do they get biometric tests on them? And someone comes in, they're possible they're COVID, would they have any of these tests that we've talked about? And what would you see? Again, not taken from respiratory.
No, it's no problem. I'll just make sure I don't repeat. Let me write this down so I don't repeat it when I talk about respiratory. No, I'm just kidding. So when they come in normally at first, if they're coming with symptoms, especially some people come in with major symptoms, some with minor symptoms. Basically, they're going to be treated, with oxygen, basic stuff like that. Some of them need high flow oxygen, which I'll kind of go over when we do the respiratory. Some need BiPAP, some need ventilation. I think we see echoes. Right now, we do not, unless it's a stat echo, meaning it needs to be done right away, or it's ordered by a cardiologist or our intensivist, which is our ICU doctors. We will hold off doing those until they have been cleared. So they might come in as, if they're positive, we'll hold off. If they're being, we have a lot of rule out patients because it takes time to get the testing. We won't do those right away. But yes, if a doctor needs it right away, we will do echoes. We will do EEGs because sometimes we're determining which direction we're going to go with their life. I mean, sometimes it's the reality. EMGs, no. Stress tests, no. But some of the other diagnostic testing, echo and EEG, those definitely we do on COVID patients because a lot of them we see COVID present in so many different ways now, lungs, heart, brain, things like that. So it's a wide range right now.
Okay, since I'm asking all the questions, I'll toss it up to the students the next 10 seconds here. Does anybody have anything for the good of the order here? All right, so we'll give you a virtual applause. Thank you very much.
Hold on 1 second. Let me stand up and bow.
Oh, there we go. That's so much better. Yeah, we love the interaction here. Yeah. Okay, great.